Well, very good evening to all of you, and good morning and good afternoon to all others who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Prashant Mehta from Faridabad, and he's going to lecture us on role of allogenic stem cell transplant in AML in the genomic area. This webinar, as usual, is brought to the Mumbai Hematology Group, supported by INTAS and managed by Perfect Square. I thank Dr. Manoj Kumar and the team INTAS, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speaker for the day, Dr. Prashant Mehta, from Program Director of Lymphoid Neoplasms and Cellular Therapy at Department of Hematology and Medical Oncology and Bone Marrow Transplant at Amrita Institute of Medical Sciences, Faridabad. And all our discussions were themselves very eminent hematologists as well as medical oncologists, and you participants for sparing a Saturday evening, morning or afternoon from whichever part of the world you're logged in. Tomorrow, that is Sunday, 27th of October 2024, from 11:30 a.m. Indian Standard Time and 7 a.m. Italian Time, your Professor Dr. Maria Domenica Capellini from Milan, Italy, speaking to us on innovative treatments for rare anemias. And let me give a weekend for our next weekend activities. Next Saturday, that is 2nd of November 2024, from 7 p.m. Indian Standard Time, your Dr. Elena Gary from Canada speaking to us on chronic lymphocytic leukemia, tricky situations in management. Now it's the time to introduce our discussions for the day. And we have a galaxy of them here displayed in alphabetical order. To start with, we have Dr. Aditi Shah Kaskar from HCG Hospital, Borivali, Dr. Akanksha Garg from Zydus Hospitals and Zydus Cancer Center, Ahmedabad, Dr. Akshay Shah from Nanavati Hospital and SL Raja Global Hospitals, Mumbai, Dr. Amrit Kaur Keller from Kokilaben Dhirubhai Ambani Hospital, Mumbai, Dr. Anup Toshniwal from Chhatrapati Sambhaji Nagar Shri V Care Clinic, Aurangabad, Surgeon Commander Dr. Arun V.A. from INHS Ashwini Kolaba, Mumbai, Dr. Avriti Baveja from Himalayan Institute of Medical Sciences, HIMS, Dehradun, Dr. Bhavani Mandwa from IMS and some hospital, Bhubaneswar, Dr. Devmanya Bhattacharya from Apollo Multispeciality Hospitals, Kolkata, Dr. Deep Gala from SGPJ, Lucknow, Dr. Hamza Dalal from Fortis Hospital, Mumbai, Dr. Group Captain Dr. Harshit Khurana from Air Force Central Medical Establishment, New Delhi, Dr. Neemya Thanda from North Okkalapa General Hospital, Myanmar, Dr. Kripa Bajaj from KIMS Hospital, Hyderabad, Dr. Kunal Chatani from Nagpur, Dr. Kunal Goyal from Kokilaben Dhirubhai Ambani Hospital, Navi Mumbai, Colonel Dr. Kundan Mishra from Command Hospital, Lucknow, Dr. Khushbu Jain from Medicover Hospital, Aurangabad, Dr. Madhupriya Borappa from St. John's Hospital, Bengaluru, Dr. Mallikarjun Kalashetty from Manipal Hospital, Bengaluru, Dr. Mona Vijayaran from SGPJ, Lucknow, Dr. Nilesh Vasekar from Medicover Hospital, Nashik, Dr. Nitin Dayal from Max Super Specialty Hospital, Saket, Delhi, Dr. Pawan Kumar Singh from Sanar International Hospital, Gurugram, Dr. Priyadarshini Peram from AIMS, Bhubaneswar, Dr. Rajan Yadav from GCRI, Ahmedabad, Dr. Riya Balikar from Wokat Hospital, Nagpur, Dr. Sachin Bansal from AIMS, Bhopal, Dr. Saswata Saha from Tata Memorial Center, Parel, Mumbai, Dr. Satyarupa Mohapatra from Bakshi Shri Shankara Cancer Center and Research Institute, Bhubaneswar, Dr. Sriram Kane from Dr. Kane Hospital, Nagpur, Dr. Sudarshan Pandit from Blood Plus Hematology Center, Nashik, Dr. Tejashwini Gudibande from RMR Road Park Extension, Karnataka, Max Super Specialty Hospital, Dr. Vipul Sheth from RGCI RC, Delhi, Dr. Vishudip Khushu from AIMS, Nagpur, and Dr. Yi Mon Tan from North Okkalapa General and Teaching Hospital, Yangon, Myanmar. Now it's the time to introduce our guest speaker for the day. We have with us Dr. Prashant Mehta from Faridabad. Dr. Prashant Mehta is Senior Consultant and Program Director of Lymphoid Neoplasms and Cellular Therapy at Department of Hematology and Medical Oncology and Bone Marrow Transplant at Amrita Institute of Medical Sciences, Faridabad. He is Senior Consultant, as I said, of Department of Hematology at Amrita Institute of Medical Sciences, Faridabad. He is at the forefront of Amrita's cellular therapy program and working to increase accessibility to CAR T cell therapies in India through collaborations with researchers and scientists. He's very proficient in immunotherapy and precision oncology, and he employs these methods when appropriate. His chief areas of interest and focus include lymphoid neoplasms and bone marrow transplant. And today he's going to lecture us of role of allogenic stem cell transplant in AML in the genomic era. Well, thank you so much. I stop over here. Over to you, Dr. Prashant Mehta.
So thank you so much, Dr. Amit, for your kind introduction. And I'm so happy to see so many of my friends actually are there in the discussants. And, it's such an elite, panel of discussants to talk to today. So I'll just share my slides. We're going to discuss the role of HSCT in AML in the genomic era. Has anything changed for us in the last many years? So that we're going to touch upon several points today. So AML has really transformed in the last few years, and with newer drugs available, newer TKIs, newer targets defined, and also we have a new vitamin of hematologists and oncologists, venetoclax, which has truly transformed the care of AML patients. I would say now, earlier in the elderly age group, but now in all age groups, probably it has really been transformative. And look at the ISBMT registry. AML is now the most number of transplants actually happen for AML right now. There's the most popular indication for transplanting, 23% actually. In the ISBMT registry, that's the data of 13 more than about 14,000 transplants actually from 1983 to 2021. So has something changed in the ELN from 2017 to 2022? Several things actually. SEPA mutation, the way we label it, it used to be just SEPA, then it became double mutated SEPA. We'll touch upon that also in some of my next slides. Now it has become BZIP SEPA, mutated like basic leucine zipper domain. That very part of the SEPA, if it is mutated, that is prognostic, not others. FLT3 ITD, we talk about it always, and we used to talk about allelic ratios, and from the midostaurin RCT, we used to talk about in which allelic ratio it is more favorable, and which allelic ratio actually confers actually a poorer risk vis-a-vis which does not. All that is actually changed. It has gone to all of it has gone to intermediate risk, none in favorable or poor, and the allelic ratio doesn't seem to matter anymore. Also, adverse cytogenetics, the myelodysplasia related mutations, the ASXL1 and and RUNX1, which used to be the only ones in the unfavorable, and some of the other mutations like U2AF1, SF3B1, SRSF2, BCOR, and the likes. These used to be in the intermediate, which have been reclassified into the unfavorable risk now. TP53, a change has happened with respect to the variant allele frequency. Anything which is more than equal to 10% VAF is actually considered significant. Less than that, we don't know where to put it. But yes, we have had recent discussions. I asked the same question to Dr. Hartmut Donor, and he said that that is more of something which they wanted to standardize it, because it's very difficult to standardize lower VAFs, actually less than 5%. But all those VAFs also may be mattering actually. But as of now, in the present classification, 10% is what is the cutoff in ELN 2022. So this is some of the changes, and this it's a nice chart actually, which actually summarizes some of these changes. Mutated NPM1 with low allelic ratio used to be favorable, now it is intermediate. Biallelic SEPA, not BSIP, plus mutated MDS genes used to be favorable, now it is adverse. BZIP in frame mutated SEPA only in one SEPA used to be intermediate, now it is favorable. No, this is in only one SEPA, that's uniallelic or monoallelic SEPA mutation. It used to be intermediate, now it is favorable. The mutated MDS genes, like the ones which I named BCOR and all, they used to be in intermediate, now it is in adverse. RUNX1 and ASXL1 always have been adverse, and that is retained. High allelic ratio is gone. It used to be adverse. It is now intermediate, and everything FLT3 ITD mutation is all clubbed into intermediate. Hyperdiploid karyotype with high allelic ratio FLT3 ITD used to be adverse. Now it is intermediate, and hyperdiploid karyotype used to be adverse. Now it is classified into intermediate. So these are some of the changes, and these actually very well are able to stratify the various risk groups now, and further stratify, in fact. It is becoming more and more refined with time. And why this refinement is actually so important, because our transplant decisions, our consolidation decisions, our TKI decisions are so much based on these factors. Actually, the more and more refined we are, the more we understand the TRM for a particular strategy, the better we can take decision whether to transplant a particular AML patient or not. So let's move ahead then. This is just a snapshot of the ELN which we have just discussed. I have just put in red these mutated MDS related genes. This we should be aware of whenever we are reading the genomic report. We should be able to find out that, okay, these are the mutations which will put the patient in the adverse risk category. And why is that important? With respect to transplant also, that is very important, because transplant really helps this subgroup a lot. So look at the other factor now. So because now we are not treating all our patients with intensive induction. So do we need better signatures, better risk stratification for patients who are being treated with Venaza? There's an era of Venaza right now. So these mutations, we will need to look at the TP53. There are 4 mutations actually: TP53, KRAS, NRAS, FLT3, and these are the mutations which we need to look at when we are treating our patients with lower intensity treatment. And these are able to stratify our patients again, and who is going to benefit the most with Venaza, we are able to find out with these 4 mutations. And this is the 2024 ELN genetic risk classification for patients with AML who receive Venaza and less intense treatments. Look at the favorable, intermediate, and adverse. The mutated TP53 is the one which is adverse, and other combinations are mentioned here. This 4 gene signature is actually there. And if we test for these 4, we have this ELN 2024 for patients treated with lower intensity treatments. So now this is some of the data now which is upcoming now, the randomized studies which are going on, where chemotherapy is being combined with venetoclax. This is also going to change the way we are treating our younger patients in future, because some of the younger patients who are unfit have concurrent infections and serious infections. They are being treated with Venaza, as of now. And then consolidation becomes iffy, and we are sometimes not very clear what we are going to do after that, because there are no very clear RCTs talking about such strategies. There is observational data available to stratify and consolidate these patients. So this is how things pan out when we compare a cohort of patients first stratified with ELN 2017 and then later on with 2022 ELN. You will see that some of 15% of favorable have gone into the intermediate. Who are these patients? These are actually the low allelic ratio FLT3s which have gone to the intermediate. What else has changed? The patients who are intermediate and had MDS like mutations, they 28% they go down to adverse. So that is a change actually. From adverse, the FLT3 high allelic ratio goes up into the intermediate risk. But eventually, you will see that intermediate, the frequency slightly proportion is increasing to 26%, but rest is similar. But there is, within the subgroups, there is some up and down movement going on, and they're refining it further. And when you add MRD to this, we'll see later in our talk in a in our today when we talk how the MRD actually is able to risk adapt some of these patients. So does allo transplant reduce risk of relapse for all ELN risk groups? It's a question. It's a trick question, you can say. And whenever I ask this question, I get different types of answers. And the most common answer I get is that actually it does not reduce the relapse risk for all ELN risk groups. I'm mentioning this because that is not what the literature is showing. Actually, allogenic transplant does reduce relapse risk for all ELN risk groups. So then you would say, why are we not transplanting everybody? There are reasons for that. Look at the risk reduction first. You see here, the hazard ratio is taken down to 0.3 and zero point 0.4 for transplant in all risk groups, actually, including the unfavorable and favorable. So allogenic transplant does reduce the relapse risk for all, and this is a very large data set here, which we are talking about. So no, just hold on. Yeah. So this is with respect to MRD. Do all MRD subgroups benefit with allogenic transplant? Again, the answer is yes. All MRD subgroups actually benefit. Even the MRD negative benefits, including all risk strata. So why are we not transplanting every AML? That is, what we should answer. So risk stratification, extremely important. Who are poor risk? We have to define very well, because these are the patients which never are going to get salvaged later on. In some of these patients, you're going to offer, your cure to about 30% of patients if you're allografting them in CR1 at the right time. So risk stratification is very important. So this risk stratification, as we discussed, is very important. But what is actually stopping us from transplanting everybody is actually the TRM. If we are able to achieve a 65% or greater chance without a transplant, then the data and the statistics is showing that transplant actually does not benefit a patient, because there is associated TRM, and that will bring down the survival of the patient, even if the relapse risk is reduced with transplant. So that is the reason we are not actually transplanting all our patients of AML, who are in all risk group. We are not transplanting them. We are transplanting a refined subset of patients who actually will benefit from such a consolidation strategy. So we need to choose wisely. And this flowchart actually, and this this table which will tell you which factors actually guide transplant decisions. So these are obviously the age, white cell count, and if there's underlying MDS, or what kind of cytogenetics the patient has, whether the patient has high risk mutations. So the risk of relapse is higher than the standard, or the favorable risk population. So there we come to know whether this population, this cohort, is going to benefit more than others with respect to doing a transplant. Also, we need to know the associated NRM. How do we come to know that? We do the HSCT-CI commonly, and that is what we can use for this decision making as well. This nice flow chart will tell us. So if the risk of relapse with only chemotherapy and followed by consolidation is less than 40%, these are not the patients who will benefit with transplant, actually. So when you're refining our risk groups with available genomics and risk stratification tools, if you're able to kind of come to a conclusion that the risk is low, less than 40% risk of relapse, then these patients actually will not benefit from a transplant. But if the risk is higher than 40%, then the TRM comes into the play, and somebody who has a high anticipated TRM with transplant has comorbidities, HSCT-CI more than equal to 2 or 3, then these patients also will not benefit from transplant. Truly, their survival will not improve with doing a transplant. But when the predicted TRM in this population is lower than 3, let's say, their age is conducive. So in those scenarios, transplant can actually benefit these patients. But obviously, this is not, we cannot be dogmatic about this. Some of the older patients are now, there are strategies which are coming up, reduced toxicity strategies, where transplant is being offered to slightly older population also now. So yes, while telling you all this, I refrain from being dogmatic. So look at this beautiful table. I call it beautiful because this helps me every day in the clinic taking decisions. This is a very nice algorithm from a paper by Dr. Craddock from UK, a 2019 paper. Look at how he has incorporated the MRD and the risk stratification into the algorithm. And he has some numbers for you from the data, actually available data, where allogenic transplant benefit is being looked at, and the estimated risk of relapse with chemotherapy versus allogenic transplant is being looked at. Also, the associated TRM in various HSCT-CI scores is being looked at. So in this table, you can very well see that you can kind of make out which patients actually will benefit from allogenic transplant and which might not benefit actually. So it is a general rough guide, when we are taking our decisions. And I do refer to this table off and on, like just for ballpark figures. So, just with this background, we have now come to understand that the more we refine our, genomics, we understand that the risk of relapse is high or low based on the genomics and the MRD. And also, we refine the way we are assessing our pre-transplant TRM and the transplant-associated TRM. These factors actually can help us in a big way in taking decisions whether we actually go ahead with transplant or not. So the first case, just as an example, a 55-year-old gentleman who is fit, has a CBF AML with c-KIT mutation, and has undergone treatment with 3+7+ venetoclax. Many fans of venetoclax in this meeting also today, I'm sure. So should we consider allogenic transplant in this situation? So I always do this. CBF AML actually is akin to this cute looking animal, the Cayenne loris, which resides in the island of Borneo. It's extremely adorable, but when it bites, it can actually cause hypersensitivity, anaphylaxis, and it can actually kill. So we look at CBF AML like that in that way, and it looks very innocent. No, it's not so innocent. There are substrata which are actually not doing well, and we need to identify that strata beforehand, so we can take our refined consolidation decisions. So coming to these refinements again, how we can find out which CBF AMLs are actually at risk for relapse. There has been some work done in this regard, and you look at especially the data from Beijing. They looked at the KIT, D816 and 820 mutations, which actually are doing very poorly. So look at the survival with transplant, some of these patients, and you see the relapse-free survival at 3 years, 66.6%, versus 6% in patients who have KIT, D816 and 820. So, these patients actually are not doing well, and 40% of these patients are the ones who were actually transplanted. So KIT, this particular mutation, D816, 820, actually was not doing so well in this particular data set from Beijing. So actually, do we know that all mutated KIT D816, 820 actually portend a poor prognosis? Are there other factors which can help us? Look at the first Kaplan-Meier actually. You see the relapse-free survival with the other KIT mutations like 822 and the wild type, it is much better. The Kaplan-Meier curves are widely separating out, so it is lower for the KIT 822 actually, 822 actually. For the 816 it's lower, 816 and 820, and the 822 it is actually better survival. So can we actually further stratify the 816 and 820? Are there ways to do that? So yes, there seems to be a way there. And this particular paper who has looked at the IL-7R transcript levels in the bone marrow and also flow cytometric expression of IL-7R, they have found that if you have a kind of a low expression of this, you have a lower survival. So within that category of 816, 820, if you have a high expression of IL-7R, you still are going to do better. So some of these patients who have this kind of biomarker, you are able to, you can probably understand that these people are less likely to relapse, and they do as well actually as the other KIT mutations or the KIT wild type. So this is some some very limited data set which shows this, but it, not in the clinic may not be possible to engage with all this biomarker expression profiling, but there may be other ways. So like the baseline white cell count and so many other factors which can be looked at while taking decisions. So but at baseline, when you look at the c-KIT D816, 820, 30 to 40% of the total c-KIT, these are actually bad. And if we are able to further risk stratify using the newer biomarkers and some of the experimental biomarkers which I'm talking about, which is coming up now, but difficult to do in the clinic, maybe we are able to avoid transplant in some. But as of now, most c-KITs 816 and 820 would actually benefit from transplant. So, and there are some c-KIT inhibitors in studies actually which could actually help in this situation. So What is the strategy for this population, the core binding factor AML population? Flag plus GO actually has the best results, and 90% of patients actually can be salvaged and can be cured with this strategy. GO may not be available to for most of our patients, difficult to get, and also there is a risk of VOD if ever we require a BMT after GO use. So if GO is available, it can actually take care of the bad biology, and very few patients actually will need a BMT if GO is available to us for this particular risk profile at least. If GO is not available, the CKIT D816, 820 at least will require the BMT. And obviously, we would also need to look at other maintenance strategies in this particular population. So just away from the CBF now, coming to SEPA, which is another factor which has kept on changing in the last few years, from monoallelic to biallelic to now BZIP. So many changes going on with this mutation, and people are trying to refine it further. And we are seeing these reflections in the newer ELN every few years. So this particular situation where a 55-year-old gentleman with white cell count of 10,000 and more and fit has a SEPA biallelic mutation and has undergone intensive induction with 3 and 7. In this situation, should we actually consider allogenic transplant or not? Let's see what the data says actually. So this, just hold on, I'm just. So just excuse me for that short break. So now we were talking about SEPA and the BZIP SEPA, which is kind of the new thing which has come up in the ELN 2022, and uh, in the BZIP domain, that is the basic leucine zipper domain in the C terminus. This is the mutation, and actually more than 2/3 of SEPA actually are in the BZIP. So how's that? So 63.6% actually are double mutated and 36.4 are single mutated. And when you look at the bifurcation where the mutation is, you would actually come to the conclusion that more than 2/3 are actually in the BZIP domain. So look at the survival difference now. There's a stark, marked difference between the overall survival of those with mutation in the BZIP domain versus not in the BZIP. So yes, it does risk stratify the BZIP, the SEPA at least very well. So, but in those who actually do not have a BZIP, SEPA, or have in some other play region in the SEPA, how do we actually risk stratify those patients? So there are some prognostic normograms available, and people have studied these, and when they have analyzed these data sets, they found that in this particular subset, older age and high WBC count. So I was mentioning the white cell count. White cell count also is a factor actually which can guide, and it has been prognostic in many of the data sets. So we can very well utilize it, because look at the hazards here. In patients who have a high white cell count, they actually do poorly in this particular subset of patients with mutated SEPA, where we are not looking at a BZIP SEPA. So this can further risk stratify our patients. Also, the other factors like CSF3R mutation and achievement of CR or not. That is very obvious that somebody who's not achieving a CR, is not going to do well. So no difficulty in recognizing that subset at least. So again, this prognostic normogram, which I was talking about, which takes into consideration high white cell count, CSF3R, KMT2A mutation, and the white cell count, and it actually assigns points to these various factors, and it is able to risk stratify into low risk and high risk of the biallelic SEPA, out of all of these. So the low risk actually, based on this prognostic normogram, actually does very well. Look at the leukemia-free survival at 4 years or so, very good survival. It's crossing 80%, and it's below 40% for those who are high risk by this prognostic normogram. So thus, you can actually further refine based on simple factors like white cell count. So if you're consolidating these low risk patients with an allogenic transplant, actually you're not gaining anything. So these patients should not be allografted, and these will not benefit. In fact, you will be giving them unnecessary TRM by transplanting. So, but if these patients are high risk by such prognostic normograms, and you are able to actually confer a survival advantage by transplanting them in CR1. So, and that there you can see the leukemia free survival is much better in the high risk, based on the prognostic normogram. The survival is much better than just treating these patients with chemotherapy. So, just by showing you all this, what I'm trying to do, I'm just trying to say that refining based on genomic factors and some of the clinical factors, the laboratory factors, can actually guide us better while taking our transplant decisions. So in the AMLs with SEPA mutation, patient who have a non-BZIP mutation, generally you would actually offer a BMT, and patients who have BZIP SEPA or a biallelic SEPA with high risk features based on such normograms, also you would actually say that okay, they can also benefit with transplant, because such normograms are showing that other factors also are important in this particular mutated subset also, which is biallelic SEPA. With low risk features, patients with this kind of situation, chemotherapy only can actually be used. So we are actually further refining the biallelic SEPA by assigning so many other factors, mainly the age, the white cell count, and coexistence of some other mutations. So when you use such normograms, you would actually realize that about 30 to 50% of patients who actually these mutations, who have these good factors, good prognostic factors, are actually still going to benefit with transplant. So that requires further refinement, using genomics and clinical factors and laboratory parameters. So this is how maybe you could arrive at some sort of sanity while taking this difficult decision. So the third case is a 55-year-old lady who is a fit NPM1 mutated AML, and she has got 3+7 induction, and she has achieved a 2 log reduction in NPM1 RQ-PCR. Will you consider allogenic transplant in this situation? So let's look at the data with respect to this. RQ-PCR positivity of NPM1 is a very important factor. And just remember that if you have NPM1 mutation with the other adverse risk factors, it lands up into adverse risk. It will not remain a favorable risk anymore. So but in the presence of NPM and no other adverse risk cytogenetics and genomics, you would actually rely on the RQ-PCR in the peripheral blood on while trying to take decisions. And patients who have less than 4 log reduction in peripheral blood NPM1 MRD levels, they actually can benefit from allogenic transplant. And there's at least 2 or 3 data sets which are available to reinforce this thought. So if somebody has concomitant FLT3 mutation or poor risk genotype, the NPM1 MRD response actually actually drove the benefit for allogenic transplant. Even the risk genotype in this particular data set did not matter. The NPM1 the MRD response actually did drive the benefit. But based on the recent ELN, we are aware that the poor risk genotypes will actually go to unfavorable only. So the most of those patients will actually be landing up, getting a transplant. So over the age of 60 years, the prognostic significance and predictive significance of NPM1 mutations still is, there is some less clarity there, with respect to even the these MRD responses and the criteria. So actually, which patients who have an NPM1 mutation would actually relapse? So MRD is actually the factor here, and patients who are MRD positive, the relapse risk you see in this study published in NEJM 2016 is 76%. MRD negative is 33%. So 33%, as we discussed in some of my initial slides, that if you have a relapse risk of less than 40%, you can there is no benefit achievable by transplanting these patients. So there you have the number, and you need not transplant these patients. But somebody who has a relapse risk of 76%, MRD positive, these are the patients actually who should be allografted. So out of the MRD negative, 33% are relapsing. Can we actually further risk stratify these? And is there something available which can guide the MRD negative patients, patients who are MRD negative? So maybe if they have DNMT3A mutations, their relapse risk again is higher. It's higher than 40%. It's 52%. So maybe these patients also could benefit from allogenic transplant in this NPM1 subset actually. So can doing a transplant salvage a patient of NPM1 mutated AML who has not achieved a deep enough NPM1 RQ-PCR, by the end of 2 cycles, let's say? So yes, the data does show that transplanting these patients is able to actually negate the effect of that MRD positivity to quite an extent, and they can actually benefit from transplant. So in this situation, NPM1 mutated, those who are MRD positive based on the data, you would definitely want to transplant these patients. And this is with RQ-PCR of NPM1. And if they are MRD negative, still, some of these patients would still relapse. And who will relapse? To predict that, maybe concurrent DNMT3A mutation can be looked at. And there could be a role of maintenance treatment in this situation, or BMT may be an option for this particular subset. So again, genomics coming into play and guiding us when to transplant based on the prediction of risk of relapse. So there's some data with respect to the MRD positive population. When you're giving oral ASA in this particular subset, you're able to actually extend the OS actually. So as I mentioned that in this particular subset, in patients who are not able to allograft, maybe oral ASA. This is a recent ASH23 abstract, which is showing the same finding actually, effect of NPM1, MRD on outcomes, and this is the subset actually which benefits from transplant. This is the Kaplan-Meier curves from this very study. So post cycle 2 PBMRD, if it is negative, they do better. Intermediate risk population has always been cause of concern, and many of these patients we are not able to actually clearly define benefit of transplant, and people have tried to do randomized studies, but they have not been very successful because the recruitment has been an issue or some or the other factor. Very clear results have not been obtained. So this is one case where 59-year-old lady, HSCT CI less than 2, transplant eligible, was treated with 3 and 7 induction and HIDAC, and the peripheral blood, the MRD, the marrow MRD is 0.3% with flow cytometry, and only a haplodonor was actually available. So will you consider allogenic in such a situation? So again, there is some data available to dig when deciding on such situations. This is from the ITAL-1 study. It was a randomized study, never completed, left in between. Here, at least, the benefit of transplant actually did not show up. So it is actually very difficult to decide, but MRD actually does play a role, more of a role in intermediate risk population on transplant decision. Obviously, the type of donor, the TRM associated, the institutional TRM of a particular type of transplant also comes into play. So patients who actually have persistent MRD positivity will benefit more from allogenic transplant. So here in the intermediate risk population, MRD has an immense use. So especially very important to really find out and refine and risk stratify these patients upfront in CR1. If we somehow are not able to transplant these patients in CR1 and we are not able to achieve an MRD negativity at CR2, these patients actually do very poorly. They absolutely don't benefit from any treatment, any consolidation. So allogenic transplant for IR risk, upfront IR population, if done in CR2 without MRD negativity, and that's an MRD positivity, is not able to achieve cures. So, some of the authors have suggested that allogenic HSCT should be avoided in these patients who have not achieved an MRD negativity in the IR population, because these patients actually, seldom get cured with this treatment. So some data from China. So they have done analysis. It's a kind of observational data, but not an RCT. So, but still something useful, because in transplant, very few RCTs are actually there, which are informing our decisions. Many of the our decisions are being informed by registry data. So this is one observational data set which we can probably look at. So this is in the IR population doing a haploidentical transplant versus only doing chemotherapy. You see here, at least in this particular data in IR population, haplo HSCT does confer a 3-year LFS of 74% versus 47.3% in the in the chemotherapy arm. So there is a difference in survival in patients who have been transplanted. OS is also better. So look at the cumulative incidence of relapse with haploidentical transplant, 11.8% versus 48% in the chemotherapy arm. The NRM somewhat more with haplo, 3% versus 15. But again, as we saw, the OS is better, the RFS is better with the haplografted population, which is intermediate risk. But just note that this is not that intermediate risk which contains FLT3 ITD. This is FLT3 ITD negative actually. So for high risk, the decisions are relatively more clear, because high risk, if they are fit and achieve a CR, we do want to transplant all of these patients. But do all the high risk AMLs benefit equally? This older data set, which was based on older ELN, and you see here that TP53 del 17p benefits less, but the 5q deletion, it benefits somewhat more if they are transplanted in CR1. But these are again observational data. So has ELN 22 changed our approach in any way? This is a very nice paper, very nice analysis, and they have done a very kind of very good statistical modeling to find out even more clear pathways on which patients actually will benefit more. So they have risk stratified utilizing the newer ELN, and also they have because the data is showing that the myelodysplasia related mutations which have been recently added in the ELN 2022, they benefit a lot, and they mirror the intermediate risk population more than the unfavorable. So they have tried to remodel, re-stratify the ELN 22 cohort. So you see here, this is a very salient feature of the ELN 2022 when it is risk adapted with respect to the myelodysplasia related mutations. And you see here that in the MDS related mutations which have been added in ELN 2022, with transplant you are able to achieve an EFS of 55% and 73% OS at 3 years. This is very different from what you are able to achieve in other adverse risk cytogenetics, that is 42% and 58%. So this is mirroring the intermediate risk population more. So this subset of the unfavorable ELN 2022 is actually benefiting much more from transplant as opposed to others. MRD also is taken into account here, and it is actually something which MRD negative population is benefiting a lot here. So 75% OS, 69% OR. This is for the intermediate risk MRD negative and favorable risk MRD negative population. This is MRD adjusted outcomes. And also if you look at the MRD positive favorable intermediate, they also seem to benefit from transplant, and you are able to achieve a OS, EFS of 33%, and by transplanting these patients, and 50% OS at 3 years. So look at this modeling, statistical modeling, which they have done. You see the transition from intermediate to favorable, or the intermediate to adverse and adverse to favorable based on the MRD before the transplant. So they have re-stratified based on the MRD, and then they are able to refine, and they're able, you see the curves, the Kaplan-Meier curves after remodeling and re-stratifying based on the MRD adjustment, the curves are separating even more widely. And so it is a more refined subset actually, when these patients are transplanted. So MRD does play a key role when you are re-stratifying your patients before transplant. So you can take those decisions again, and it's a dynamic assessment actually before transplant, including MRD with your genomics, and then you know that TRM is a factor. You keep that HSCT CI alongside, and then take your transplant decisions. So in the era of as a when, all that stays, or it changes. But the data, this paper from TCT journal, and this is from Winters et al. It does show that patients who actually get transplant after a lower intensity treatment like Venaza, they also seem to benefit as much from transplant, at least from the observational data which is available. Now, there is also some Markov analysis done, using Azaven versus induction chemotherapy for fit patients. So this is some of the Markov analysis graphs. So I'll just give you a summary of what they actually found in the adverse risk. This is quality adjusted, because quality of life is a major factor with the Markov analysis. So you see here that in the adverse risk, the Azaven actually is somewhat superior to intensive induction, and when combined with allogenic transplant and quality adjusted, again Azaven plus allogenic transplant is scoring above induction chemotherapy, intensive induction plus allogenic transplant. So in the intermediate risk, again, the DFS, if you look at, then Azaven plus transplant versus intensive chemotherapy plus transplant is almost neck and neck. And uh, in without transplant, the intensive chemotherapy is actually, even in the quali, it is scoring above Azaven. So there's some hint that in the adverse risk population, if you're using Venaza followed by allogenic transplant, you can probably get a better outcome versus induction chemotherapy. In intermediate risk, is it looks like more neck and neck. You look at the quali, intensive chemotherapy plus uh, ASCT is almost as good, probably doing as well as Azaven plus allogenic transplant. So this again from propensity matching, and if you look at the overall survival, again with induction chemotherapy versus Azaven in favorable and intermediate risk, intensive induction slightly has an edge. And in the P53 mutation, though, Azaven seems to be having an edge over induction chemotherapy. In the intermediate risk population, you see, looks like induction chemotherapy again is scoring over. But when combined with allogenic transplant, as per the previous plot I showed you in the previous slide, looks like neck and neck again. So this is a very nice paper in JGO from our Indian group only, and they seem to advocate that most patients, if you transplant in CR1 in India, you can actually save some money. Because at relapse also they actually spend a lot of. So this is one thought. I don't know how many of us can actually incorporate in our practice, and it's not that they have been dogmatic in their paper, but yes, it is a thought actually. And when we talk amongst us, then we many times we talk that, okay, maybe a risk stratification, a refinement, is the genomics, everything. We are not actually doing all the genomic parameters which actually may be required, and newer genomics are coming into play every year, and we have new data coming in. So maybe we should transplant more patients, and who are fit. So that's a thought. But again, are we benefiting those patients always? So we again can't be sure. The data with AML CR2 transplants is actually not as bad as the data for ALL CR2 transplants. So if you're transplanting an AML and CR2, but just remember that I did show you a slide where intermediate risk population who has not managed to achieve a CR2 with MRD negativity, they actually don't benefit much from transplant. So we need to risk stratify in CR1 better for those patients. But that said, the CIBMTR registry data does show that the outcomes are not so wide apart between CR1 and CR2 AML transplants. But when you look at ALL, you will see the curves of CR1 and CR2 actually are wider apart. So AML at relapse, maybe you could say slightly less difficult than ALL at relapse, but it's again very difficult to say. But that could hold true for most of our patients actually. So, but relapsed ALL transplant outcomes are lower than relapsed AML, CR2 transplant in general. So maybe we could wait for CR2 for many of these patients. So that's a debate, and we will need better and better genomics, refined genomics to find out, and biomarker analysis and the clinical laboratory parameters to actually define which patients will actually benefit. So this is the CR1, CR2 gap in ALL versus AML, which I just tried to elaborate. And my take home would be, let's risk stratify better, refine our risk stratification upfront better, and at CR1 better, incorporate MRD adjusted algorithms, and we also look at the TRM, HSCT, CI, because as we just saw that you can actually reduce the relapse risk for every risk group, and also for every patient who has MRD, irrespective of MRD, you are able to reduce the relapse risk for everybody with the transplant. But the problem is you're not imparting a better survival to them, all of them, using a transplant. So the TRM does come in a big way. So we have to actually look at all these factors, refine our risk stratification, look at the TRM, and then take a decision whether one particular patient, which we are treating right now, uh, will actually benefit from transplant or not. So seems like a tough job. Thank you.
Thank you, Dr. Prashant, for a wonderful lecture. It was wonderful data points you showed, whom to transplant and whom not to transplant, covering everything, intermediate risk, high risk, low risk, even transplant is essential for low risk. Now we know that from your data points. Thank you so much. Fantastic presentation. Lovely presentation, I may say.
Thank you.
And I request now all our discussions to please put the raise hand sign so that we can start our question answer session with Dr. Prashant Mehta. So just to keep the ball rolling, I'll ask you one simple question regarding the c-KIT mutation, which you said about D816 mutation.
20, yes.
And the
Yes.
other factor which is very important with that patient should have that IRL7, which should be, if it is present, then you may not transplant. Am I right?
Yeah. So if it's a high expression,
High
then
expression of
better.
it, high
Yes.
expression of it, you may not transplant. So is this
They,
being
this
done?
paper actually studied the transcript levels in the bone marrow at diagnosis and at expression in the flow cytometry. This is what they did.
Okay. So are you routinely
So,
doing that actually, or you seeing that?
no. We are not routinely, but the type of c-KIT mutations we are routinely doing. So that is a factor which actually help us. At least we know that which type of c-KIT mutation it is.
Absolutely.
And also we should incorporate c-KIT more and more in our algorithm of decision making, because the CBF AML is a touch point when we are treating, because many of these seem to relapse despite whatever we do, and we are thinking, okay, are we actually dealing with favorable risk here or something else is going on?
True. And another question is, if the patient is CBF AML with c-KIT mutation and you've given the patient flag plus GO, do you still require to go for transplant?
So yes, so in this situation, probably you will be able to avoid transplant for most. If you have used GEO, it is able to take care of your risk with the poor prognostic marker of c-KIT. So maybe with GEO use, you could avoid a transplant.
Thank you.
Right.
Dr.
If you
Satrup.
have GEO available, very few will actually require a transplant. Maybe
Absolutely.
only 5 to 10% of these patients.
Absolutely. Dr. Satrup, your question, please.
Hi, sir. Thank you for your presentation. It was really very concise, covering all aspects. I had a question regarding like P53 mutated AML. It's difficult to treat. How would you approach? And would you treat a monoallelic P53 and biallelic or multi-hit P53 differently? So, what is your opinion there?
So you have asked me something which I keep asking everybody, and I have not got the answer yet. At least I am not sure whether we have come to a situation where we know how to treat TP53 mutated well. Whichever data set I look at, whichever strategy I look at, it seems to be translating very well for all the other risk groups, barring the TP53. So the even the lower than 10% or whichever type of TP53 we are looking at, no, I'm not sure whether we can actually differentiate based on that as of now. I asked this question to Dr. Donor just 1 week back, 10 days back or so. But whosoever I asked this question, I have not got the answer. So TP53 mutated AMLs are all bad. And I think if you're able to manage achieving a CR using Venaza, I don't think we should be using intensive induction in this population at least. That we can be very clear of. And then most of these are, these patients are chemorefractory. So if you're able to achieve a CR using using Venaza, what I would do is I would try to allograft them. I don't know, you tell me what you all would do, but I would try to allograft if I have achieved a CR1, if they are fit.
Any other question, Dr. Sadrup?
Yeah, another one would be like in NPM1 mutated AML. If at the end of single cycle of induction, a patient is MRD positive, would you put it as would you transplant that patient, or I'm talking about like just after induction MRD positivity?
So I will just follow that data set. So after 2 cycles, if somebody has not achieved a 4 log reduction, so that would be kind of an indication that the patient will benefit from transplant in the RQ-PCR NPM1 peripheral blood. This is what the data I could find. So I would do the same. If somebody is not achieving RQ-PCR 4 log reduction after 2 cycles, I would look at transplant. But there is no, in the new ELN paper, very nice. They have given an AML CRLL subscript, low level. So some of these patients we have treated, and they have completed therapy, and they have the level of transcript which is below the clinical threshold of prognostication. These are the patients who can actually who may not actually relapse. So they have designated it as CRLL. LL is a subscript there. So these are the patients which really interest me and intrigue me. But yes, the answer to your question would probably we just follow the data with respect to the NPM1 RQ-PCR after 2 cycles.
Thank you.
Thank you, Dr. Satrupa. Dr. Akanksha, your question.
Hello, sir. Good evening. Thank you for that very comprehensive talk. So I just wanted to know your opinion regarding one case of elderly AML that I've treated. She was NPM1 and FLT3 ITD positive. And when she was diagnosed, she was around 69, 70 years old. So I started her on azacitidine with venetoclax, and I added on midostaurin also. So basically, now she's completed like 12 cycles of Aza-Ven plus midostaurin. And after, when I gave her 2 cycles, after that, she had become MRD negative. And so I just continued with the same treatment. But now after 12 cycles, I did a peripheral blood MRD. So that was negative. So I just wanted to know, in such a scenario, how would you, would you continue giving the same? Or because, there's not much data of midostaurin continuing as maintenance beyond 12 months. So what would be your take for managing this patient?
I think my take would be that I would continue therapy for as long as tolerated, and Mido I may drop at this point because your patient is MRD negative, it seems.
Yes.
And what I tend to do is I keep cutting down the Ven dose significantly.
Yes.
At the end of 1 year, I keep cutting it, and sometimes, let's say beyond 2 years, maybe I cut on the AZA dose, and I make the frequency of AZA also less frequent.
And you would recommend, monitoring the PCR every 3 months. That should be continued, right?
I think I would do that. I would continue monitoring, I think.
So midostaurin beyond 12 months, I think that would, it's better to stop it and just continue on the Aza-Ven and probably just keep tapering the duration.
I think major benefit what your patient may be getting, to my mind, seems to be from Venaza.
Yeah,
It's,
but
so
actually, I
moving
mean,
on to
to
something
tell
very
you the
literal.
truth,
Tell me.
she's been receiving the, she's not taking the original venetoclax. I mean,
Okay.
when I started, she's taking the other one, the
Okay.
Bhutan one, and
Okay.
I'm giving her 21 days of
Okay.
venetoclax.
Okay. And
So
she's
that's
tolerating that well, 21
yeah,
days?
yeah. She's actually tolerating. She's not having, she has, the counts are around, maybe TLCs around between 3,500 to 4,000. But we've done a marrow also in between, a second marrow. It was absolutely normal. So that's why, I mean, I'm just continuing that. But I just wanted to have your opinion regarding the
I think,
midostaurin.
no, I think you have done wonderfully well with this patient, and whatever you're doing, you should continue that. And this patient has been managed very well by you.
Yeah, thank you so much. So thank you, sir. Thank you for the opinion.
Thank you, Dr. Akanksha. Dr. Deep Gala, your question, please.
Thank you, sir, for this wonderful overview. Sir, I have a question regarding NPM1 AML. Sir, there's a patient which we have come across who had NPM1 exon 7 mutation. Usually we see NPM1 exon 12 mutation, which are the most common. So then, sir, how do you take this? He's a young male, 20-year-old who came with a NPM1 mutation, but it was in an exon 7 mutation. So how do we risk stratify this patient then?
So non-canonical mutations, I think it's better to dig the data and look at the Cosmic database and look at the, there are some online databases which I can, if, if you can, mail me, I can share, at least I can share you the databases which can give you more information about non-canonical mutations. And you can look at the data available with respect to that mutation. So offhand, I am not aware of what exactly this mutation would signify, but I would look at the databases available and then take my decision.
Yes, sir. And so the second question is again pertaining to NPM1 FLT3 ITD positive AML. So if the patient is around 50, around the age of 55, 56-year-old, and otherwise he's fit, no comorbidities, performance status is very good. So what will be the induction regimen of choice right now? Will it be an intensive induction or will you proceed with a less intensive induction of aza-ven, sir, in such a case?
So you're talking of a fit young FLD3 mutated AML. That's
Yeah,
what?
55, yeah, 55-year-old, fit,
5-year-old.
otherwise
So I
fit,
think
no
I
comorbid.
think I as of now we have Mido available in India, so I would go with intensive induction with midostaurin. That's what I would do as of now based on the available data, and I would see if these patients can be allografted based on the fitness of the patient. That's what I would at least do. But yes, the data with quizartinib is as exciting, with the gilteritinib is as exciting. So any of these drugs actually can be combined with intensive induction. But uh, I'm not so sure about Venaza in all such situations. I cannot give you a blanket recommendation. The RCTs are on right now. There are RCTs. Some groups are doing RCTs. Some of these are investigator-initiated RCTs, and I did show you the Markov analysis on the intermediate risk population. So it is kind of neck and neck, but intermediate risk, the intensive chemotherapy is slightly right now, and especially with the TKIs, it is right now something which needs to be standard as of now. But yes, all that is changing. It is a dynamic situation with Azaven right now. But you're right that with chemotherapy, chemo-ven combinations, and TKI, alongside when all these are being tested, but there is no clarity as of now. So as of now, I'll go with the data of 3 and 7 induction plus midostaurin.
Yes, sir. And so the last question is pertaining to FLT3 AML. So what is the role of FLT3 inhibitors when the patient of FLT3 AML is transplanted in CR2, sir? Not in CR1, transplanted in CR2. So role of FLT3 inhibitors post-transplant maintenance for such patients, sir. Because the data suggests that the role is not clear. So I would like to hear regarding that, sir.
So I think if at all I would use a inhibitor post-transplant for AML, maybe it could be sorafenib based on the RCTs which we have in upfront transplanted, some of the transplanted patients with the FLD3 mutation. The other data set which excites me is the gilteritinib NGS MRD positive before and after transplant. So if somebody is NGS, because NGS FLD3 actually is coming up in a big way for FLD3 mutated AML. So if somebody is NGS MRD positive pre-allo, I would maintain them post-allo with gilteritinib.
Thank you, sir.
Thank you, Dr. Deepkala. Dr. Amrit Kaur Kello, ma'am, your question, please.
Thank you, Dr. Prashant. It is a wonderful discussion in this genomic era. And just to introduce myself, I'm not into actively treating any hemat patients. And I was just looking into all the mutations that you have discussed. It's certainly an amazing data, and we just look into it, how the mutation is behaving and how the risk stratification that we do it on a daily basis. The thing which we need to consider, just a small understanding of my little subject, which I understand is if we have the NGS testing is significantly important right now. Yes, absolutely. But then we also need to look into the co-mutations which are present. Sometimes with the NPM1, we do have a TET, we have IDH1, we have FLT3, NRAS, WT1. So when we do the risk stratification, we do need to monitor them because monitoring is important. And I understand if we achieve a MRD at a molecular level to 0, I think the stem cell transplantation will be much more beneficial. That's what is a genomic consideration when we look at the genes and the mutations, because prognosis, yes, prognosis is poor. Some of the mutations are difficult to treat, like WT1, the chemotherapy does not work. But some of the mutations like RAS, cytarabine therapy works. And until and unless we receive the complete MRD on on NGS, I think we should wait for that. And as you have rightly mentioned, so much of data that if it is not completely achieved, the CR is not achieved, then obviously this risk of relapses is more. But have you ever considered, thinking in terms of whether the mutation is somatic or germline? Because P53 can be a somatic mutation, it can be a germline mutation. So the relapse, did you see in your practice that germline P53 had a higher rate of relapse as compared to the somatic P53 when it is less than 10%?
So with respect to the germline and somatic question, I have seen more of germline in ALL actually. P53 mutated ALL seems to have more of germline. P53, is hypodiploid ALL. But in AML, I have not seen many germline TP53s, but I've seen more somatic. So with respect to that, I'm not in a position to answer you whether the germline P53 does worse or somatic TP53 does worse. But yes, the germline TP53 would have so many other factors involved, and they would be at risk for so many other situations and second malignancies that the decision to transplant them, the decision to treat them, and with what treatment will take that into account also. So, but with respect to AML, it's very difficult to say. But the DDX mutations is one subset where germline testing is indicated in the older population. It's MDS associated, and they do respond well to the azaven based treatment. Their survival is better with azaven. So we look at these mutations as some other mutations like which we generally do find, like GATA1, and some of the other mutations which are there in associated with AML, germline tendency to get AML. Those we do look at, and we look at the family history, and in the presence of those mutations, probably with the available strategies, maybe Venaza would score over. And the second question you asked me is about the NGS MRD. Yes, so I'm not sure if we are doing NGS MRD as in any center as of now in AML at least. Just doing a targeted NGS panel or or hotspots or an NGS myeloid panel, that is not truly doing MRD actually, because MRD is done in a different way for AML. And NGS MRD strategy in ALL also is big right now. So many people would say that just doing mutations is NGS MRD. That is not the case. So with respect to ALL, you need to do the BCR clonality, IGH sequencing, and then assess the dominant clones at baseline. So all that is kind of up and coming in India. It's going to take shape. But right now, what I can rely on comfortably in AML at least is the RQ-PCR for particular mutations. So that is what I'm trying to do as of now, and flow cytometry, which is available to us. So what decisions we are taking, MRD adapted decision, are based on the flow cytometry and RQ-PCR as of now. But yes, you're right, many other things are coming up. The leukemic stem cell flow cytometric MRD is also coming up in a big way. So, but that is, to my mind, right now in the experimental domain. But one of my colleagues in HemePath is actually in our center looking at LSCs. She has done some preliminary work, but I'm not sure we are doing very well with respect to the NGS, MRD, and AML as of now.
See, I just have a genomical, experience which says that if I look at a TP53 mutation, even if it is a solid tumors, I take care of both solid and hematological. And if it is a germline mutation, the chances of reoccurrences are higher. In solid tumors. So if I apply the same to the hematological malignancies, I do see that if the VAF is higher and the patient is not completely transplanted, obviously there will be some clone which will pick up again and it might lead to a relapse. So that's why we go back and we do the testing for germline to understand if there is a risk of reoccurrences and relapse in those patients. So maybe that could be one thought which can be, we can start referring patients based on that if the VAF is around 20 to 50%, because so mosaicism is something which is very common in hematological malignancy. So if there's a wide range between 10 to 50, we start looking in this aspect just to understand our patients better.
Very right that we can, VAF can be an indirect indicator of having a germline mutation. But the problem, which we have faced with that is because, we need to actually achieve a remission first, and then maybe use a buccal mucosa or, maybe use another tissue to ascertain actually whether this is actually germline, and then do parental testing. In fact, in one of my patients, I did all that, and I found that he did have a de novo TP53 germline, which is kind of a rare event. So, but I did, find in one of the kids actually who had such a, and the parents were both negative for germline. So, again, it becomes very difficult to actually find out at the outset at diagnosis, because at that point in time, it's very difficult to say whether actually, even with the high VAF, it is germline or somatic. You will need to wait for before you, after you get a remission, and it is going to be difficult for you to get a remission with P53 AML in any case. That is not the case with ALL. With
Yes.
ALL, you are more likely to get a CR, in at least in the first newly diagnosed situation, and there are more treatments available, more targeted strategies available. With AML TP53 mutated, you're kind of in a difficult situation, and some of these patients are older, so and then they may not be very eligible for treatment, and then you're giving Venaza, and so and their also response rate may be to the tune of 50-60%, and that may not be MRD negative in most situations. And then again, finding out whether this germline may again be a little difficult. Just my thoughts. As a clinician, I face this challenge. That's why I'm just trying to tell you.
And we are all thinking with you for all the patients. And thank you for the patient understanding. Thank you.
Pleasure.
Thank you, ma'am. Dr. Nimya Thanda, the question, please.
Thank you, Dr. Prasad, for your excellent presentation, and it is valuable for our patients. I'd like to know the maintenance therapy after transplant from your risk assessment, sir.
Okay. So for maintenance, you're talking of post-transplant maintenance?
Yes, post-transplant maintenance in high-risk patients, sir.
Yeah. So I think what from the available data, what I would like to do is maybe at least for the FLT3 cohort, I would rely on sorafenib, and again with the data with gilteritinib, which says NGS MRD FLT3 positive at any time point, maybe gilteritinib, and there is some preliminary data with respect to azacitidine, which can be incorporated. But beyond that, I don't have many options. All the data with venetoclax, with other drugs, as maintenance is and obviously midostaurin has not shown any benefit, and quizartinib has not shown any benefit. Whatever data I can as of now look at is with sorafenib, or with gilteritinib. So I would look at those, and with obviously patients who are not allografted, ASA data is the strongest. So those are the strategies as of now which are doable in the clinic. Others, I would say right now, most of those would be experimental.
Thank you, sir. Um, uh, in our settings, we have limited resources. So should we, I'd like to know your suggestions. Should we add maintenance therapy after post-transplants in high-risk patient?
Okay. So I think that would take into account the pre-transplant MRD. And if that is, if there's a patient who has MRD positive pre-transplant, and you allografted, then maybe what I would do is maybe for the FLT3 mutated cohort, I would consider sorafenib. Sorafenib is not an expensive drug, and can be managed. At least we tend to start it at 3 months or so of transplant, once the transplant related complications have abated, and we're able to start such a drug, and then maybe continue up till a year or so. That could be a strategy. And again, same with ASA, at a lower dose, maybe nearly about 50 or 60% less the dose you use for the induction. Maybe such a dose could be actually employed and customized for your patient post transplant with high risk profile at transplant.
Thank
So
you
these
very
are
much,
the
sir.
strategies which may be doable in a resource constrained environment.
Thank you, sir. Thank you.
Thank you, Dr. Thanda. So there are some questions from the audience.
Surely.
Dr. Nakul Tikare wants to know, keeping out the finances, how do you decide between GEO versus dasatinib in c-KIT-mediated CBF AML? Because recent papers have shown that dasatinib is much effective than, though not conclusive enough, than GEO.
So dasatinib is again, it falls into a domain of less robust data, but yes, exciting and promising. So I would right now stick to GEO-based treatment for this situation.
Absolutely. Another question from Dr. Shushma. Does any other molecular mutations other than FLT3 and DNMT3A with NPM1 affect the prognosis?
You're talking of the NPM1 cohort?
So NPM1 plus FLT3, NPM1 plus DNMT3A, any of that combination will affect the prognosis?
Yes. So if you have any of those adverse risk cytogenetics or the MRC, MDS related genetic mutations, or any of the, RUNX1, P53, ASXL1, SRSF2, STAG, U2F1, SRSF2, all these mutations, SF3B1, all these will actually put your patient in the unfavorable risk category. So they do affect. So that's why a broad NGS is important right now, which incorporates all these mutations in the algorithm.
True. Another question from Dr. Bhavani. 30 years male, translocation 821 with ASXL1 mutation, post 3+7 induction in remission, given 3 HiDAC currently, right now on 3rd HiDAC currently, if patient goes into MRD negativity for translocation 821, should this patient be considered with allogenic stem cell transplant?
I think with respect to the ASXL1 mutation, this would fall under unfavorable risk. So I would actually allograft this patient.
True. And another question is 40 years male, NPM1 mutation positive, with DNMT3 mutation also positive, post ESA-WEN 2 cycles, MRD is negative, and RQ-PCR is negative for NPM1. Should this patient be considered with stem cell transplant?
So this patient is how old?
40 years.
So the patient has been treated with ASA-WEN induction because of what reason?
It's not mentioned.
Okay, the reason, many of us who treat AML, we know that we want to avoid TRMs and we want to avoid complication toxicity. But right now, the data with treating this particular subset with Venaza is not very clear. It's okay that many of us are pressed to do that due to many reasons. But when I ask the same question to some of our colleagues in Europe and US, they're not able to digest it very well. And we because, and when I ask whether such a patient can be given consolidation HIDEX or transplant, they say, okay, which kind of treatment strategy are we following? Because Venaza as of now has not been touted as a curative strategy. So although it may be curing a small subset of patients. So if you have used Venaza, then I am at crossroads on deciding what I'm going to do. If the patient has achieved MRD negativity, maybe I will just continue Venaza for the time being and treat with Venaza. That's as of now what I can think of. So if you want to consider transplant, you have one reason, you have DMT3 DNMT3A at least. So maybe that could be factored in, and the baseline white cell count could be looked at, the age of the patient, the fitness of the patient, and then maybe considering that situation at a higher risk of relapse. And because with Venaza, the risk of relapse would be definitely higher with Venaza alone. So you could argue that your relapse risk is more than 40%. Your TRM is low with transplant, patient is 40-year-old. Considering that logic, and you have not been able to use intensive induction upfront because of some reason, maybe the fitness, maybe the logistics, whatever be the reason. So maybe using that argument, transplant may still be superior to not transplanting and continuing Venaza.
True. Another question from Dr. Krishnaratham Kannan. For NPM1 mutated AML and core binding factor AML, at the end of induction, if there is a good log reduction but negative, as you said, can you wait till consultation before deciding for transplant?
Yeah. What is the log reduction here? 3 log, 4 log, 2 log?
So it is more than 4 log reduction.
More than 4 log reduction, it's okay. Acceptable. So more than 4 log reduction, the data is clear that you can continue your consolidation and you can complete your HIDAX and just follow up.
Well, transcript is positive, but more than 4 log reduction, but then you can go for still.
So, yes, you can still, because you have achieved the prognostic cutoff already.
Absolutely.
And we did discuss that below the clinical threshold of that particular test, if you have some positivity, you will be labeling it as CRLL. So that can be observed as per the current recommendations.
Absolutely. Another question from Dr. Shushma. Can you briefly tell us about, will you proceed for transplant in RUNX1 mutated cases?
Yes, I will proceed for transplant whenever they are in CR1. Yes.
True. Another question from Dr. Indrani. 69 years male, transplant ineligible AML with 5q deletion, achieved remission with 12 cycles of EZA plus VEN. Now in EZA maintenance, 2 months interval. Is there any role of addition of lenalidomide to this patient?
And this is this is an AML patient.
AML patient, 5q deletion.
So I think I would have just continued the AZA-VEN only.
Absolutely. Another question from Dr. Emont. Yeah. Another
So
question.
I would not use the lenalidomide in this situation. Yeah, it's okay.
Absolutely. Another question from Dr. Emont 10. Your management for MLL rearranged AML, especially those who have short remission, while arranging for stem cell transplant in relapse cases.
Okay, so you're talking of a relapse situation or somebody who's in CR already? Relapse.
So patient was AML, rearranged AML, had just a
KMT2. Short remission, and the patient relapsed.
Relapsed,
So
and
now
now stem cell transplant.
this is a particularly again a difficult subset. You could try something which combines venetoclax with chemotherapy, or again azaven if the patient has not been exposed to it. And if the patient has already been exposed to azaven also, then the investigational drugs will come into the play, like menin inhibitors. Revumenib has some data in this situation with respect to the KMT2A. And if you are able to achieve, maybe as far as I remember, about 50-60% patients will achieve CR with that particular drug. So if you're able to access that drug, then probably allograft after you have achieved a CR. And if you're not used up your azaven and venetoclax based strategies, then use that and then allograft if you achieve a CR. This is a young fit patient you're talking of?
This is young fit patient.
Okay, fine.
And another question she has, if there is only partial remission only in young relapse cases despite FLAG-IDA, azaven, how should you proceed?
Okay, so can you tell me, you're talking of a situation where the patient has, let's say, a 5 to 25% draft.
We have got ML, rearranged AML, especially very short remission, relapsed, arranging for stem cell transplant. Patient, they have used EZA-WEN, partial remission, flag IDA, partial remission, arranging for stem cell transplant. How should you proceed?
So AML with active disease transplanting, there are strategies now available, and there is, there is a strategy using, even with haplo protocols, the Beijing group has tried, and there is about a 10% or so, or 10 to 20% possibility of achieving a long-term outcome with these patients allografted in active disease, but it's going to be difficult, I'll tell you. Transplanting an active disease, I have seldom been able to achieve good outcomes, very hardly any. So I have been lucky very few times, and those patients have survived. But with active disease, allografting is going to be challenging. There is, there is an approach to that, and you could allograft them. It is not as bad as allografting an ALL in active disease. You should never allograft an ALL in active disease, but an AML, you could still get a small subset of cures.
True. Another question from Dr. Emon Tent.
Okay.
Yeah, the same thing will be possible to maximum MRD blast. Yeah, maximum of MRD blast percentage according to your experience. When you will take transplant.
Can you come again? Come again.
If you want to take the patient for transplant, how much of the blast percentage should be there, cut off, to take the patient for transplant?
I am okay with a morphological leukemia-free state. For AML, I'm not bothered by MR. I'm not wanting that, everybody should be MRD negative, because there is no data showing that if a patient is MRD positive or has some little bit of disease in the marrow, you treat that disease and get an MRD negativity, and then your outcomes are better. There is no data to show that. Additional therapy to achieve MRD negativity, as we do for ALL, that is not the case with AML. That's the difference between AML and ALL pre-allo management. So MLFS is okay to transplant.
Perfect. Another question from Dr. Priyanka. Post-consolidation maintenance in AML with FLT3 positivity who are not fit for transplant, is there any data of midostaurin maintenance post-consolidation for 2 years?
So you're talking of transplant ineligible FLT3 mutated patients?
Yes.
Or not transplanted due to some reason?
Not fit for transplant.
Not fit for transplant.
Yes.
So you could give them, as per the study, you could give them maintenance, but the maintenance has not shown much advantage. Maybe I would consider ASA maintenance for these patients.
Absolutely. Another question from Dr. Yimon Tent. Which factors will you consider to choose oral ESA maintenance? And what would be the duration of maintenance with oral ESA?
So I think I would consider all patients who are in any risk group who have not been allografted due to any reason. I would consider them for as a maintenance, especially the ones I showed you, the NPM1 residual MRD on MRD testing, and those who have any degree of MRD positivity and have not been allografted. For them, I would choose as a maintenance, and the duration would be 1 to 2 years.
Absolutely. Well, so I finished all the questions from the audience. Any discussion I want to ask? Any question to Dr. Prashant Mehta? So I think now there are no more raising signs. And yeah, Dr. Nilmia Thanda, your question? Okay. So I finished all the questions from the audience, and there are no more raising signs. Well, thank you so much for the fantastic lecture. The data was excellent. It was eye-opening for all of us. Many data I was not knowing about this, about high risk regarding the DNMT3A, which you talked about. That was really fantastic. Wonderful discussion. You solved wonderful doubts of us.
Thank you
Thank you so much. Hats to you. Superb lecture. Fantastic. And I request all our discussants and audience to again participate tomorrow for our meeting at 11:30 a.m. onwards. Thank you so much.
Thank you so much. Have a good night, everyone. Thank you. Thank you.